I'm gonna get started, because I think that people will be coming in, and probably a lot of you, there's lots of familiar names, so lots of you will have been to these sessions before. So to introduce myself, I'm the Regional Learning Coordinator for Social Prescribing across London, and it's an NHSE role supporting link workers across London. I'm based at the Healthy London Partnership and work alongside my colleague Justina. Justina, do you want to introduce yourself?
Hello, I'm Justina Sobotka. I'm social prescribing project officer in Healthy London Partnership, working with Liana, making sure that we've got nice peer learning sessions organized to share our experiences. I also am responsible for the newsletter, so if you'd like to share something with others, please do contact me. Both about this and the newsletter. And I'm also an ex-link worker, so I also can answer some questions based on my experience in this role.
So Justina was one of the link workers that was coming along to our peer supports and peer learning sessions, and has recently joined the team, so really fab to have her. All of the organisation for today has been Justina. So she's, if you've got suggestions for future sessions that would be useful, there's also a raft load of other sessions that we've delivered. Go back and look at the back catalogue, the library. It's all on our website. Justina can chuck a link in the chat. Today we're talking about caseload management and ending with the client. I think when running peer supports, we get to hear a lot from you guys around some of the challenges that you're facing, and I think this is a massive issue for many of you. Having huge numbers on your caseload, having developing really strong relationships with your clients, to the point where it's very difficult to let go, especially with some of your more complex cases. I think, you know, being able to share with each other some of your top tips. As we know, social prescribing is not delivered in the same way everywhere, but many of you will have insights into the way that you like to handle things, and this is an opportunity for us to hear from some link workers and some professionals around what they do in order to manage their caseload and bring a relationship to an end with a client and to close off the case. As we know, social prescribing we're all about empowering the individual, and ultimately what we want is, by the end of our intervention with a client, that they are in a place where they're better able to manage manage themselves. I'm going to ask if everybody that isn't speaking can go on mute. Jenny, can we go to the third slide with the agenda for today? So as usual, this is a really informal session. We're going to hear from a number of people who are link workers themselves, but also a counsellor who's going to be talking a little bit about kind of setting boundaries with clients and how to develop, manage expectations from the outset, but develop that sort of longer term trust, so it's not a surprise when perhaps that relationship comes to an end. There's going to be an opportunity for you to ask questions and share any of your own top tips at the end of this. We'll do that at 1:30. In the meantime, please talk to each other in the chat box. Pop your questions in there. If you've got something that you want to ask or say, it might be that we can pull some of you in to ask your questions as we're going. Like I said, this is a very informal session, and it's as much about connecting with each other as it is about listening and hearing from some of the examples that are being shared. If you could change your names to put your borough after your name, I think that will be helpful, so that you've got a bit of visibility and you can each see who else is in the room. This is going to be recorded, and we will share all of the slides and the recording on our website. Hopefully that will go out in the newsletter, which will be landing tomorrow morning. So as Justina said, keep an eye out for that. If you're not already signed up, then please do sign up for the newsletter. Okay, enough from us. I'm going to hand over to Paula to kick us off. Paula.
Hello.
Do you want to
Hello.
Hi.
Thank you for inviting me. Someone going to play my slides, or do I?
So we've got the slides up. So if you want to.
Thank you. Okay, so my name is Paula. I'm a counsellor working in a low-cost placement in Ealing, and I'm also the co-director of an organisation called Yardo, which offers affordable wellness and well-being opportunities such as mindfulness, counselling and support groups. So they're affordable and inclusive. That's our jam. And today I'd like to share my experience of ending well with clients, healthy endings, which I hope, you know, are relevant to other helping professionals. And, you know, perhaps we can have a conversation or a Q&A at the end and share ideas. So of course, different clients have different ending styles. If you think about the way you are when you leave a party, there are different ways of going about things. And as a therapist, we want to set things up so that we're offering a consistent experience and a well-managed experience for the client. If you don't mind playing the next slide. These are the topics I will go through today. For me, the beginning of the relationship is very important, and the ending should be flagged up from the beginning and throughout the whole treatment. So I'll take you through these topics one by one over the next 10 minutes or so, and then give you the opportunity to ask questions. Next slide, please. There is research in psychotherapy called common factors. And that research demonstrates that whatever type of therapy you offer the client, it is the relationship that the client has with the counsellor that is the most curative factor of all. Far above whether you're offering CBT or psychodynamic or another type of helping relationship, it is the relationship that's important. And I've really taken that on board as a therapist, and I do find it's incredibly helpful. So I focus very much on building an alliance with my clients from the outset. I do that by being warm and empathic, so the client does not feel judged and know that they are safe in my hands and in this relationship. I use good listening skills. So I will be using reflective listening skills, reflecting back bits of what the client's saying every so often, so they know what they've been heard. I will be paraphrasing sometimes, sort of summing up what the client said, which can be very useful for the client to hear back for themselves what's going on for them. I will be minimizing my use of questions, and even within my own mind, I'll be withholding judgment. I'll really be offering that good listening, which in and of itself is curative. If you've ever been really listened to, really deeply listened to, it feels great. So you're going to be doing your client a great service just by employing those good listening skills. But more importantly, I think, is that you can really hear why they are there, what they think their problems are, what they think their problems are, and also what's unsaid. And congruence, which is a type of mindfulness, helps you with that. Congruence, being aware of what's going on in your own body. How are you feeling? What are you thinking about this client? Being aware that this is separate from what the client is saying to you, but might also have some relevance or use. So that self-awareness is so helpful. So you're not muddling up your own thoughts and feelings with what the client's saying. So the combination of these things, the empathy, the listening, and the self-awareness, so that you can make good judgments about what you propose to the client, what you say to the client, these all build a very trusting relationship. You'll come over as authentic, and the client will really feel able to cooperate and allow themselves to commit to the process. Some clients...
Can I ask you a really quick question, actually? Maybe you're going to go on to talk about this, but could you say something about kind of the contracting that happens at the beginning, the managing expectations?
Sure, I'll go on to that next slide, I think.
Oh, right, great.
The last thing I just wanted to say about the relationship building, I'm really focusing on it because that's what I do in the therapy. The relationship is so key. For some clients, that alliance can be built up within the first 10 or 15 minutes. I've had a client where it's taken an hour and all contracting, nothing happened until that alliance felt secure. Next slide, please. So, on the basis of that relationship, you can then, I believe, bring in the contracting. I don't ever start with the contracting. Be very clear, how many sessions does this client have? How often are those sessions? How long do they last? What happens if the client misses a session or is late? For me, a very important issue is about contact between sessions. So for me, my clients can contact me by text or WhatsApp if they wish, but I will not look at those texts or WhatsApp until the day of the therapy. I mean, sometimes I look at other times, but I tend not to contact them unless it's the day of their therapy. And they know that. And that protects you as a helper from feeling that you need to be available at all times. But the main thing is that this has to be clearly expressed and agreed to with the client. Also, in this bit of the contracting, which I call administrative, I would mention that there will be a point at which you're going to review your agreement and review your contract and make any changes that might be needed. That might be where you decide to extend sessions or reduce the amount of sessions, something like that. But as long as the client's aware that whatever is happening is going to be subject to agreement, and then there will be an opportunity at some point to review that agreement. Next slide. So, I've just spoken about the administrative contracting, so the client knows what's going to happen and when, they know what to expect, and there are no nasty surprises. In terms of the goals that you and the client are going to agree together, I think it's helpful to be very specific and realistic. If you only have a short amount of time, you can't solve all of the client's problems, and you can't go into very deep problems either. You're probably going to be looking at more behavioural issues like losing weight, learning, perhaps challenging isolation, joining a group, something like that. And I'd be very clear about who's doing what. On the whole, I would be encouraging the client to do as much as possible in the tasks that are going to be agreed, and that promotes the client's autonomy too. So once you've got these goals, whatever they may be, again, I personally would subject those to writing, and I would be reviewing those every so often, so that by the time we get to the end, there are no surprise endings. We followed a plan, we kind of know what our plan was. Next slide, please. Underpinning all of this and supporting all of this work is your boundary setting. You have to hold those boundaries with the client, the things that we talked about in the administrative contract. I definitely find, I must admit, I don't always manage this, but I can 100% vouch that when you do hold these boundaries very tightly and very securely, the work goes a lot better. So for example, in my work, clients pay for their sessions, and if they miss a session, they still have to pay unless they tell you by a certain time. Even if they're 1 minute over that time, the boundary is upheld. And that makes everybody clear and safe about what's happening. It depersonalizes it, which keeps you safe. You don't have to feel that you're treating one client one way and another client a different way. Yes, of course, this boundary setting and this firm boundary setting is supported by what we spoke about at the outset, that warm, trusting alliance that really supports you being able to hold those boundaries. And of course, the boundaries are very important for your own self-care, so you're not doing too much, doing more and more, responding more and more. Next slide, please. When it actually comes to the closing sessions, I wouldn't say sessions, what do you actually do, and how do I actually manage those? Well, I don't know how much of this will translate to your own work, but as I mentioned earlier, I would generally have flagged up the ending 1 or 2 times throughout the relationship. oh, you know, we've got 3 weeks left, how's it going? That sort of thing. On the penultimate session, I would generally use it as an opportunity to raise anything that is perhaps disappointing the client, what's not been done, what might have to be left behind, and to discuss those issues. Some of those things could perhaps be resolved before the last session, but some of them we have to tolerate. We can't do everything. We have to model to the client that we have to tolerate unfinished business sometimes. We have to tolerate uncertainty sometimes. We have to tolerate things not being perfect. And your modeling of that's going to be helpful to the client. In the final session, I tend to focus on what's been achieved, recapping what's happened and highlighting to the client anything positive about them, where I've seen they've changed or how they've resourced themselves. This would also be the time, you know, to do any signposting. I would expect that you'd have things in your back pocket. So, for example, I have options for where suicidal clients can go. I have options for, you know, eating disorders. I have options for perhaps autism screening, these sorts of things, and you'll have your own options. But the main thing is, you and the client would have agreed at the outset what the plan was. You'd have been clear who was doing what. You would have been reviewing this along the way. And by the time you get to this final session, you can recap what's been achieved. You can just highlight again for the client what the follow-up procedures are. Can they return to the service at any time? Of course, that would be in the written agreement I mentioned earlier. And, you know, all of this supports a nice, safe closure. Things have been discussed, things have been agreed, things have been clear. You've upheld the boundaries, you've modelled those good boundaries. And in that way, I find that the last session, whatever has been achieved, can be ended in a satisfactory way for both parties. That's it. Next slide, please. I think the next slide is just, yeah, if there are any questions or any comments, please feel free.
Paula, it's me again. How are you? All right. Yeah. Can you hear me, Paula?
I'm here, but I can't see you. So could you just say who you are?
It's Elaine.
Oh, hi, Elaine.
Hello, my dear.
You.
Nice to see you again. I think as social prescribers, we don't have a formal written agreement with our patients. There's a general understanding, and that can sometimes become a little bit blurred. So I think probably very similar to what you were saying, there's that constant reminder, and it seems to be easier for our patients to kind of, I suppose, forget the boundaries that are in place, because we don't have that formal agreement, although it's a verbal agreement. So we find ourselves having to constantly, with every follow-up, remind the patient of where they are, what we still have to do, how the process and how far they've achieved, and that reminder of not it's going to come to the end, but there's the constant reaffirming that they're along that road and they're moving forward. So I don't know whether or not we would have a written agreement, but it does sound quite interesting for us, actually.
I think it sounds, Elaine, as though you are aware of what the agreement is. You probably have it written for yourself, I should imagine, and that you are reminding the client of that on a weekly basis, perhaps. And I think that's very helpful. I don't know whether you could put those 2 or 3 things in an email, something like that. But the important thing is that the client is clear and they know what direction you're going in and what you're trying to achieve.
Some, as you say, some they cross the lines. They attempt to cross the lines, and I think the lines are quite blurred for them. But yeah, it's and it's also different in that there's a financial agreement. I think when people are financially connected to something, there's very defined boundaries there.
Thanks, Elaine. What I find really helpful about the written agreement is that it depersonalizes it, and it can come from the service. So you can have that lovely relationship with the client and say, but it's the service that says you have to be on time, that you have to give notice, that you can't talk. And obviously that's very freeing for me as the helper to get on with helping and not to have to feel as though I'm personally withholding something from the client.
No, I agree. Thank you.
This is really
Paula,
interesting.
we've got, sorry.
I hear this a lot, actually. It's Leanna talking. Can we stop the slides for a second so we can see everybody? I feel like patients adding last-minute issues is something that link workers are dealing with a lot. It's in previous work, working with children and young people, it's that, you know, it's in the car before you're going back into the house that you get the sort of the full disclosure, or those moments when you know something's coming to an end. It's almost preparing for that next the next disclosure, or maybe going sort of to another level. Have you got any suggestions on how that can be managed, both in expectation setting at the beginning and then what to do when that situation arises?
Yeah, I think that's very common. I mean, on the one hand, that very careful listening and that openness and that relationship is what hopefully will allow the client to actually bring the genuine issues and the real issues and not save them up till towards the end of the relationship. That's one of the important things about that alliance building, and really doing a job as you can of that. Beyond that, even within a session, I think you should flag up the ending. Say, like, there's 15 minutes to the end, there's 10 minutes to the end, because then that's when the client might say, oh, actually, there's this real thing that's really what's actually really bothering me. And, you know, hopefully they don't do this on the final session. At least if it's done on the penultimate session, which is really quite good, on that penultimate session where you say, what hasn't been done? What do you think, what do you wish had happened? And give the client the opportunity to bring that forward. And if they do, if somebody at the end of a session says, oh no, this is a real issue, then you hold the boundary and say, I hear that. I really wish I could address that right now, but we've run out of time. So can we put that for the next session? Or, you know, something like that. Is that?
I think this is really interesting, because many of you around the table now, some of you will have very fixed number of sessions that you're working with somebody for. People can be referred to social prescribing more than once. And if there's a main thing that you are going to be focusing on in your series of 6 or 8 sessions, if they feel that they want to tackle something else, you might deal with multiple things in your sessions, but if there's something else that's really, as Paula's saying, is really kind of a big piece of work, I think it's thinking about whether or not there's a justification for to be referred again. I think I'm sure we're going to talk about this a bit later, but there's obviously that risk of, there's always going to be something. If we think about ourselves, you know, we're never, you know, striving towards perfection, I'm sure, but never, you know, there'll always be something, there's always more that we can be doing. And I think it's knowing when to say that this is for somebody else to be managing now, or it requires another professional, or perhaps a re-referral. We're gonna go on to our next. Thank you so much, Paula. Feel free to keep putting comments and questions into the chat. I'm also really curious to know who's got a work phone, and there was I'm going to pop up a quick poll. If you could, in fact, I don't know whether or not I can do that. I can do that. Can I do that? There we go. So I know that some of you have put that in the chat, but it'd be great if you could just answer that as well, because I think this is the sort of stuff that's really useful for me to go back to ICS leads and NHS England to say, it's really important. You guys are dealing with very complex cases, and with the pandemic, more and more sort of mental health patients that are struggling with their mental health. So really important that you're not using your personal phone, or you're not feeling that you have to. Who have we got next, Justina?
We've got Elaine.
Yeah.
Elaine, if you could unmute yourself.
Hello there, everyone. Hello, I'm Elaine. Hi, I'm Elaine Mulligan, and I'm a social prescriber based in Ealing. I'm employed by Ealing GP Federation, and I cover 5 different GP practices. I'll wait for the slides to come up because I don't want to bore you again. Okay, this is some. I've been involved in in NHS and voluntary sector settings as a therapist, and various other hats for over 20 years. So these are just a couple of the things I've done. I was an ABA therapist, working with children through social engagement programs, and also in clinical settings as part of the diagnostic team in NHS settings, as well as the National Autistic Society. I was a child stroke manager as well, working with Stroke Association, the NHS and Evelina Children's Hospital. Quite a few different roles in charity sector settings as a health and wellbeing manager, which I've thoroughly enjoyed as well. And I missed the NHS and decided to come back, and hence here I am now. So next slide, please. Well, the poll's doing well.
I feel slightly encouraged, actually. Three of you. I feel three of you that aren't that are using personal mobiles, and perhaps it's worth dropping us a note just to let us know who you are.
Yeah, that's a good response. Okay, social prescribing in my PCN, which again it covers, like I said, it covers. I'm in a different GP setting every day, so I cover 5 different practices, which was I only started in July, so it's I'm settled in now completely now. But in the beginning, for the first couple of weeks, I have to be honest, it was different place, different way of doing things every day. But I'm there now. How it works in this particular PCN, Central Ealing, is that patients previously, and Justina knows this, had a 60-minute assessment time. It's now been reduced to 30 minutes for the initial assessment. I don't always follow that because human beings aren't machines, and I do what I feel I need to do. And quite often it is well over 30 minutes. I was 1 hour and 50 minutes this morning. So I do what I feel is necessary for the patient, but officially I'm supposed to provide only 30 minutes. And there's an average for each patient, there's an average expectation of 3 to 5 follow-up appointments. You get the occasional patient that I'm dealing with who maybe only needs 1 or 2, and some well beyond 5, sometimes up to 7, and potentially even more. Again, that goes on. That's to do mainly related to complex cases. The expected, now I say expected, weekly referral is because CCG and Ealing GP Federation have an agreed number, which is 15 new referrals daily, which is, well, I could receive the referrals, but I certainly won't be getting through all of the referrals. So on average, I'm expected to go through a weekly average of 75 new patient referrals. I know, I just saw the measures from Caroline, thank you. Referral Origin, there's only one of me, Michelle, there's only one. I'm covering the 5 GP surgeries. I'm just, sorry, I'm answering the chat. The referral origins mainly coming from GPs, other health professionals, especially the nursing and the pharmacy teams that are based within the clinical settings, and an admin do as well, and secretaries. The secretaries deal a lot with a lot of the patients' queries. And there's also that they've had 1 or 2 a couple of self referrals since I've been in post. So that there's always that option when patients see the flyer that within the clinic themselves, they can. I think it's maybe on the website as well, I'm not sure, but they have access to, a lot of them are just nosy as well. They just want to know what I can do and what I'm about, and there's always something I can help them with. So that's, at the moment, that's the referral origin at the moment, and I'm not sure what plans are to extend that to other health professionals, social services, etc. Next slide, please. Oh, caseload management. Now, I have to be completely honest, I'm not an expert, and I don't always practice what I preach, because again, humans, individuals, and they have different ways. There's different ways you manage individuals, as Paula mentioned. But on average, at the moment, there's the average of 45 contacts that I'm with patients each week at the moment. And the average contacts, I say, averaging 9 daily, sometimes a little bit more, because quite often I'm following up on patients to see whether or not there's any updates on the referrals I've made, or have they received their counselling confirmation, etc. Or sometimes it's to do with housing. As you all know, what we do is a myriad of different things. So quite often it is follow-ups as well as new referrals. So again, the new referrals, I have to allocate a little bit extra time. And the referral process itself within this particular PCN is that health professionals all use the System 1 database. I don't know if you might be using a slightly different one, but they're all pretty much the same. I think previously my predecessor was presented with new referrals via the what's called the tasking system, where she would probably come in and see a number of tasks assigned to her. That still happens, but I think what they've done now is they've given me a rota. So every day I go in, just like all the GPs and the nurses, I have my own rota, and I see throughout the day in half-hour blocks which new referrals I've got and which are follow-ups. So and I manage that myself, and GPs can obviously add in a patient for me and book a patient if they want that patient seen that day. And I've done the occasional home visit, so I'm open to that. And I do a number of in-clinic face-to-faces as well, which I think a lot of patients are really appreciating at the moment. Again, Referral Origin is other health professionals and the patient self-referral. Tracking patients and follow-ups and being on top of what you've promised and where the patients are in their process. Again, System 1, I use System 1 database to task myself and remind me to send, so I can date it and put in a patient's needs. Please contact Mr. So-and-so on this date and check on the referral, blah, blah, blah. I can use that, which is a sort of instant messaging thing that only goes to me. And I also use, which is something I've always used, which is an Excel sheet. I use a separate thing as well. So I keep a double whammy myself with this one. I know I give myself too much work, but I like to have an Excel sheet which helps me monitor in real terms. I can see that from the moment I've had the referral to the first telephone call, to the second contact, third contact, and so on. I can see where I am and where the patient is. I'm quite a visual learner, so that's how it makes sense to me to have everything in color coded and along an Excel sheet. I'm sure everyone else does it in a different way. Some people take informal notes, some maybe just have the one system they use. I use the two systems, mainly the Excel sheet, which I think works for me, and it just helps me keep an idea of where the patient is and the progress. Especially if I get a phone call put through and I want to see that person's history in front of me without actually spending too much time on the database. Next slide, please. Again, I'm not an expert because I've made so many mistakes in over 20 years. I have learned, but it quite often, like all our guards slip sometimes. If we're all completely honest, I'm sure. Whether you're a support worker, counsellor, family worker, whatever your background is, therapist, we've all done it. We've all lapsed and allowed people in a little bit longer, and not always been clear on our role to them and not being clear on the ending. But it really is important that we stick to this. And I think we just have to remind ourselves, just like you do safeguarding training every year. It's important to remind yourself about this as well. So I think it's important to set, as Paula said, set the expectations early. And again, like we were saying, it's throughout. Like every time you speak to them, is that constant little sort of reminder here and there that this. Remember, I'll be giving you. We've got another phone call next week, and as soon as that thing happens and you get that thing in place, then your time with me will be reduced or potentially over, but it's just very subtly done. There's never the idea of an ending. I don't do it that way because I don't like people to panic. I think it's important to communicate, so set expectations early from the very beginning and consistently throughout, and communicate effectively and clearly. Don't leave things wishy-washy, because if you're not clear and you don't communicate clearly, it confuses the patient or the client, and they're even more they're confused as well. And that's when it can lead to people complaining and, bad atmosphere, which is never good for anyone. Don't be afraid to say no. I think sometimes, especially in the beginning, when you're new to a role where you're working closely with people, and especially those with complex needs, you tend not to say no because you don't know how to say it. So saying no, you don't have to necessarily say the word no, but refusing to do something because it's not part of your remit, or it's not essential, is important to understand and develop that ability, because I think in the beginning, when you start working with people, it's hard to say no. But and stay in control of the relationship. Sometimes patients and clients can veer you and start controlling you. That's happened before for me, I'll be honest, where I think, my goodness, have I just said that and done that and I've agreed to that? But yeah, it's really important that we stay in control and look after yourself. It's quite often, like Paula was saying earlier, if I work in a different GP practice every day, and I don't deal with the clients or the patients on those days, only on those days. I'm not chopping and changing all over the place, just purely for my own mental health. I think it's important to put your own self first. And you're not being selfish. You just have to put yourself first, so that you're in charge, you're in control, and your time's managed well. Otherwise, you will be going to your own GP, looking for your own social prescriber. Ending the relationships with the patient. Again, as Paula said, it depends on the patient and how you're dealing with them. Quite often, there's an understanding from the very offset, and the patient is fully aware and is able to understand that. And others that just keep coming back again, those re-referrals. But preparing the patient prior to discharge, that the end of the support is imminent, I think is something that you can do, like we said at the beginning, throughout, and then just as you know it's all coming to an end, that's when I would start saying things like, "Oh, you're doing so well. You've met all the targets we've talked about, and you're ready to go out on your own, and everything's fantastic." So I use a lot of positive reinforcement just prior to this, and with a little reminder that it's our last session next time, and to maybe think of other ways that we can. I can support it. Maybe, sorry, I got distracted by a pop-up there. Sorry.
That's me. Sorry, I just have to put it for everybody to get a bit of a sight on how many patients we're all seeing per day, and I'll do another one on your KPIs for the year. So what your caseload looks like over the course of a year. So I'll pop those.
Yeah, that's good. That is such a good idea. I'd be interested to see that.
Sorry, could I butt in? Sorry, just about the poll and the quiz, if that's okay.
Yeah.
Sorry. Yeah. For me, I find it really difficult for me to be choosing any of them, because on average, every day is different, you know. And I think I've worked really hard within my PCN to get clinical staff to understand that we're not like GPs that have those 10-minute appointments, because some days I could speak to, like 10 patients, but then the other day actually I only get to speak to one. So it's really difficult to ever sort of make any sort of single choice, because every day is different, and sometimes maybe I don't even speak to many patients because I'm just following up referrals and emails and so it really depends.
I think in this case it would be good just to have a bit of an appreciation that we're not going to, no day is going to be the same, but maybe there is a best case average. It sounds like in your case it's probably up to 5.
Like I said, not always. No, sometimes it's really difficult. Sometimes it can be up to 5. Some days it can be more. It's really dependent on my caseload and what's going on within that surgery, because some surgeries may not be as sort of have patients that have less sort of complex needs, and so I could get through more. But then other surgeries I find actually have patients with higher needs. So I don't know if I feel comfortable with saying yes, it's this one or that.
No, fair enough. Perhaps the next question around the numbers of people that you're seeing per year is all the expectations around that might be more appropriate, because then you've got a bit of a snapshot of the volume of people that you're seeing? And obviously, like you say, some of those cases are going to be more complex than others and need more time. I mean, it sounds like you're in a good situation if you're being given time to have, you know, you've got the freedom to see just one person or and have some admin time. And I don't think that's necessarily the case for all link workers. No. It sounds like, you know, that challenge of getting GPs to understand your role is a common one.
Absolutely. That's why, I think it is so integral and so important for GPs and for other members of staff to really understand the sort of social side of what we do. And it's not a tick box exercise, you know. And I think because we do have a really good sort of team leader as well, who's constantly sort of trying to share that message. And I think we do have targets that we've got to meet per year, and every month, you know, I let every surgery know how many referrals that they have sent and, you know, how far are we off for the year target. But they can keep sending me referrals, but it doesn't mean I can open them straight away. I try and do a sort of a 1 in, 1 out kind of thing to make sure that the support that I am given is quality and is, you know, comprehensive, rather than sort of tick boxing and what's the word, just kind of lip reading, if that makes sense. Was it called lip reading? I don't know what that's called. Like, you know, when you just
service.
Say, lip service. Thank you. Yeah, lip service. Exactly.
No, I agree. I have the same. I think we're all going through the same situations. And we worry that the need for targets is overriding their need for the patient's needs for a quality support. That's the problem. Yeah. It's a constant. We're firefighting all the time.
No, I agree with you, Elaine. Absolutely.
Okay. Yeah. Shall I just quickly whiz through this and then we can move on to the next session? I know that ending relationships with the patient, again, it depends on the individual, but quite often we have our own little way of doing it, our own personal system. What I tend to do is go back and reflect on the goals that they've achieved, because at the beginning we've already set the goals of what we want to achieve, and there's an agreed support plan in place. So we look at that, and then we can see visually what the patient's achieved and that they've achieved those goals. So that's a nice way of preparing for the end, and to support patient confidence by developing support networks and a support network plan. So instead of just saying, that's it now, goodbye, James, you're off now, it's nice to have a kind of discussion as you're winding things up to talk about the future support that's in place. Remind them what's there, remind them that you've put X, Y, and Z in place and that they've always got X, Y, and Z to speak to, and at the end, leave the door open for a possible, like we said earlier, re-referral. You know, once that, I think a lot of patients feel quite relieved that it doesn't necessarily mean it's the end. There's always that in 6 months or a year's time, there is that possibility they can come back for additional support. So next slide, please. Tips on how to end it with the patient. Oh, I'm no expert, but sometimes, like I say, it depends on the individual, and you've got to see how that path that you've taken together measures out and how it progresses. But ensure the patient's journey is clear and understood straight from the start, because that'll make your life easier at the end, and the patient's. Be completely honest and transparent throughout the whole relationship. So every session, don't make promises you can't keep. That's a big one. I learned the hard way with that one as well. So don't make my mistakes. And 20 years ago, of saying to people, I'll do this, this, and this, and it's not worked, or it just wasn't able to happen. So be completely honest. It saves a lot of time and distress. Prepare the patient for the ending. For example, point out positive outcomes and the progress that they've met. Highlight support network in place. So, you know, again, it's going back to giving them that feeling of a safety net that's there when they do leave. They can always self-refer, or there's already, what about X, Y, and Z in the community? You've always got that support there. So reminding them of what's there, that safety net. And at the end, also, it is nice because it's a nice feeling of closure if you could send a feedback questionnaire. That's another one that subconsciously patients will feel, oh, you know, and also they've got input into the support then as well. So I'm going to end it there, guys, because I know that we're on a bit of a time. I know there's an agenda.
Thank you. That was really helpful, Elaine, and I think it's really good to walk through the process. You've touched on tons of things there that I think are really important: managing expectations, thinking about how much time you have with the clients. I think I was kind of curious, and I think maybe it would be good for you guys to share in the chat with each other if you've had any training on managing caseloads and thinking about how you can end with a client that you found really useful. If you've done some stuff that you think that you want to share with other link workers, then pop that in the chat. We've got, so I've just put up the last poll, and I'm going to share the result. Who have we got next, Justina?
David.
David, thank you, Elaine.
Thank you.
David.
Yeah.
Hi.
Hi. Yeah, I'm waiting for my slides.
Great.
Hi. So I'm David. I'm a social prescriber in Kilburn. My background is I've worked with people with learning disabilities. I've worked with the blind, deaf, and obviously I've been a social prescriber now for 2 years. We also do a small role as a care navigator as part of the role. And we're in a team of 4 social prescribers across 4 surgeries. Next slide. So my appointments are usually about an hour. I'm flexible. What I've learned is I've learned over time that I don't call people back the following week. I think it's really a really good tip is give yourself 2 weeks, because giving yourself a week is just not realistic. So that's the first tip I would say. Always try and make appointments every 2 weeks unless it's something urgent. Obviously, it's important I make time every day to do all my admin. I do approximately 4 to 5 appointments a day, but that's also without the people that are calling me up. So I'm probably about 5 to 6 a day. But you see in the next slide where it was before. But I think obviously it's really important to have time to do your activities and obviously have time to do training. Next slide. So like I say, 10 to 12 patients a week obviously sounds very different from Elaine, but the way I've calculated it is I see 4 to 5 a day. I have 3 days of surgeries. So 10 to 12 are the patients I see, but I haven't included the patients that call me or call back. So I would say I'm probably close to about nearly 20 patients a week, but again, that's doable. Before I was doing 20 patients plus. During COVID, I was probably doing 20 to 30 patients, which I thought was not doable. I think I've learned that the only way, if I'm going to give the right service, I've got to look after myself. That's another tip. You've got to look after yourself. No one's going to look after you. I mean, obviously your team will or your manager will, but you've got to, I think it's really important that you work your timetable. So if I look in the morning at my appointment book and I know I've got 4 to 5 appointments, that's to me quite doable. And I've got obviously the extra tasks and people calling me, that's definitely doable. But when I was doing 7, 8, 9, or even 10 a page, I don't think that was working. And it was stressing. I don't think I don't recommend it. I mean, obviously if other people do something different, but again, bearing in mind that if my appointment's 45 minutes to an hour, there's no way you can really do 10 properly. Like I say, I was doing 20 to 30. I'm now down to 10 to 12 plus the extras. I usually offer 3 to 4 appointments. It's very flexible. I find even some patients actually only need 2 to 3. Of course, and then there's obviously patients. If you're going to do a housing case, then that's going to go on for much longer. I use emails to organize my caseload. It works really well because you can always back check what you're doing and what you're not doing. Obviously using an Excel and a Word sheet as well to obviously follow up my patients. I always plan my next appointment with the patient. I always say to them, I will speak to you in 2 weeks or 3 weeks. Some of them are flexible. Some want to know the time and the date, so I give them straight away a time. I will say that, okay, I am good at managing, but I am very aware that I do have patients that I've been with a long time. And I think it's not a lot of patients. I mentioned 1 or 2, it's probably more. I think these are the patients that are, it could be a housing, it could be mental health, it could be generally somebody that wants to speak to me every 2, even once a month and I've kept them on my caseload. I haven't asked them, I haven't completed with them, but I think that's okay. But I think most of my patients stick to the usual 3 to 4 appointments, 5 appointments, and they're discharged. Next slide, please. Yeah, boundaries. Obviously, it's really important to talk. I find it's not always so easy to do on the first session, because I think the first session you're just trying to even just connect with the person and make a connection. So, but I do obviously talk about the plan, how many times I'm going to see them. We mentioned obviously the phone. I find obviously over COVID it went a bit crazy when people were calling me at all the strangest times. But again, but another tip, it's really all about you. If somebody's calling me and I'm on a call, obviously I either can answer them when I finish my call, or I can text them later. But I think it's really, really important. You have to manage your caseload. If someone's calling you and they're calling you constantly, I think it's about you obviously making the boundaries as well. So I find most patients, most of my patients are quite good with the boundaries. They know when my appointment is, they know what we're going to do, but there's always going to be 1 or 2 patients that are going to be a little more difficult. And I think with them, it's just about being really clear. I've got a patient that's on the spectrum, and she says, please, can you text me exactly what I've said? Listen, if that's what she wants and it makes her calm and it works, I send her a text or a little email saying, this is what we agreed, and it works. But I think most of my patients, if I've agreed something in the first or second session, they agree, and there's not usually a problem. Ending with my patients, I find most of my patients, if it's a task, or if they've even got 2 or 3 tasks, I think they're quite clear. When I'm clear, they know that I'm with them for a certain amount of time. They're always surprised I'm with them for so long. I think the fact that I'm giving them so much time, I think they're always surprised that I'm giving them hours of my time. But I know that if I'm giving them 3 or 4 sessions, I'm giving them the time. I think they know that when we finish the task, that they're quite good at saying, okay, we've understand. I think maybe also the reason that works so well is that I've found that people that do want to come back, and there's not that many, they've got my email, they've got my phone number, they can call back the clinic. I think it's quite easy on one hand to end the relationship, because they know that if there is a problem, they would call the surgery, they would text me. Obviously, I'm not going to give them an instant response, but I think it's about having the relationship. If I'm speaking to somebody for over a length of time, 3 or 4 or 5 sessions, you're getting to know them. I think they know that you're going to finish the task, but you also know in the back of the mind, on one hand, I'm saying goodbye, but they also know that if there was something, you could get back to me. That's, I think, most of my thing. I was trying to be quick, but I would say my final tips of the day is, we did this recently in a training. It was training for mentoring. I think the Superman theory that everyone talks about, you really have to realize that you're not Superman. And if someone's got 4 issues, mental health, housing, benefits, you're not going to be able to do everything for them. And I think it's about being really clear with them and saying to them, listen, I can help you with the benefits. I'm not going to help you with this, and not say I'm not going to help with them, but maybe make it very clear what you can do, and obviously the amount of time you've got with them. I think it's really, really good just to be clear and honest, and not try and do everything, because you're never going to manage it, and not to overstretch yourself. Because at the end of the day, I think another tip is, like I've said it a few times, you've got to look after yourself. No one's going to look after you. You're the one in the conversation. As much as everyone knows what you're doing, you're the person that's talking to someone. And I don't need to say that I've got a lot of very, very difficult patients that can be very trying, very challenging. They can be very exhausting. I'm not saying it's perfect. I've got a lot of patients that can be difficult. I know it's just about being patient, talking to them. I think it's, as long as you're aware that, I think it's just about you looking after yourself. I think that's my punchline. Look after yourself and don't overstretch yourself. That's
brilliant. I think, and there's, again, you've touched on a few different things there. Looking after yourself, I think it's thinking about who else within the PCN that is there to support you. Who can you be going to? If you're concerned about the number of people that you have on your caseload and you can't manage it, think about who you can be leaning on and be sharing that problem with, because there are a number of different solutions, and we're hearing lots of different tips here. Who can you be going to work through this issue? Caroline earlier said about there being a case for increasing the number of link workers. I know that, you know, the number of link workers in your PCN, David, has mushroomed, and I think it's going to the PCN, showing that there's a case to grow grow the team, and explaining that really a link worker should be working with up to 250, depending on complexity of cases. And if there is a higher target within your PCN, so that they can be meeting the number of referrals expected for your local population, they need to be getting more link workers, and they should have access to funds for that within the ARRS funding. So definitely, you know, think about who you can be leaning on to make sure that you are looking after yourself. Thank you, David. That was super helpful. Michaela, I think we've got Michaela next.
Sorry, just putting my camera back on. I'm here. There we go.
There she is.
Hi, everyone. So I will first start off by saying that what works for one link worker won't work for everyone else, because everyone's PCN works slightly differently. So my name is Michaela. I'm a link worker for Streatham PCN, and Age UK Lambeth. I work collaboratively with them, and I've been in post since 2019. I did have previous experience working within the NHS, and I think that might have been a saving grace to dealing with the multiple different personalities that we have to go through in this role. Next slide, please. So my initial appointments are booked for 1 hour. I explain the nature of my role so the patient is aware of how I can help and what my limitations are. I then create a personalised care plan as a guide for the patient's goals. Follow-up appointments are 30 minutes, usually via phone. We review actions and targets achieved. Unless it's a case of simple signposting, I work with a patient between 8 to 12 weeks. That's bi-weekly, so every 2 weeks we'll have an appointment and see what the patient's done with their care plan. Next slide, please. On average, I work with up to 25 people a week. I ensure that if I have face-to-face appointments, I take regular breaks in between seeing them. I do manage my own diary, so I oversee booking my patients in. This is very useful as our roles need flexibility in order to partake in training, pair learning, clinical meetings, and community development projects. Next slide, please. Professional boundaries. So, guys, I advise patients what day I work for their practice and my working hours. That's because there's 7 surgeries in my PCN, and I'm the only full-time link worker. We have a part-time link worker who joined in April. Before that, it was just me. So all contact in person or via phone has to be booked in advance, but they're welcome to email me anytime. This also leaves a paper trail so you can collate evidence when you present case studies or reports to your PCN. I no longer share my work mobile thanks to 2020 COVID, as receiving multiple texts and calls out of hours was very demanding, especially if I'm already working out of hours and tempted to answer another call. Ending the relationship with a patient. All targets on their care plan need to be achieved or in progress. When there is evidence that the service they were referred to will offer longer term support, that's when I have the discussions on discharging. Next slide, please. So my top tips: 1, ask to oversee managing your own diary and booking patients in. Set yourself realistic targets. Ask yourself how many patients sorry, I saw a message pop up. Ask yourself how many patients you have capacity to see each week. Prioritize urgent cases first and ensure you take breaks throughout your shift. We're no use to anyone if we're burned out. If a particular case is proven difficult, speak with a pair for advice and raise the issue in a clinical meeting, or if you have a good working relationship with your clinical director, I would tend to do that. Monitor how you've enabled a patient to become proactive and evaluate whether the patient is ready for discharge. I've sped through that because I'm time conscious, but that's what I'm doing. Thanks.
That's really interesting. I know lots of link, I've just put it in the chat actually, but I know lots of link workers have got, will have waiting lists for their less urgent cases, and actually have got the, you know, they've almost training the GPs that or the people that are making the referrals in managing expectations before even that person has gone over to the link workers. If they deem that person urgent, maybe they're putting that in the referral. And if not, then they may communicate even before that person's gone over to the link worker to the patient that there's going to be a bit of a wait, and it might be a couple of weeks, but they will get seen. I think there's definitely, it's the thing that keeps coming up here is burnout, and I know that we're going to hear from Conchia next, who is based in one of the voluntary sector organisations in West London. I think there's something else around, and this is what David was speaking to as well. You guys are not, you can't solve all of the problems of the person that you might be seeing, and I guess it's thinking about in the very early stages of engaging with your client or patient, thinking about the voluntary sector organisations, volunteering programmes, community centres that you can be referring them on to, who have a remit to be supporting that individual in the longer term. So if you have a time limit in terms of number of sessions or time that you're spending with a client, thinking about what assets you've got in your local community that you can either refer on to or support the development of, to make sure that there is a volunteering programme that runs alongside you, perhaps, that is that might offer some befriending. So actually the attachment that your patient develops with you perhaps runs alongside somebody that is going to be around in the longer term. Thank you, Michaela. So we've got Conchia, and then I think we'll open it up to the room for any top tips, and then from 2 o'clock, if any of you have got some tricky caseloads that you want to discuss, or you want to chat to some other link workers about specific cases that you're struggling with, there'll be an opportunity for us to have a bit more of an informal chat. We can pop people in breakout rooms if that's useful, depending on how many people are around. Let's go over to Conchia.
Hello. Hi. Okay, I'm good to be here. So I am Conchia Albert. I'm the head of social prescribing at One Westminster, which is in the name, so it's in Westminster. A little bit about me. My background is in social policy and sociology. I've worked in the voluntary and community sector for 17 years, mostly in Westminster. I've done some work internationally, and I'm a trustee in 2 organisations in Westminster. My role previous to this one was in health and wellbeing, and I led some of the work at One Westminster around this remit. Okay. So I'll talk a little bit about social prescribing in One Westminster and what that looks like. I'll say the first thing that we do when we get a task from a GP or another health professional is send a text message to the patient to say that we've received a referral and we'll be in touch. And we do that within the first week. And that just stops people from getting worried about whether their case has been looked at or someone's going to contact them. Often we do that through a QRX. And if they're not digitally included, we would use sort of sending them a letter, something like that. The initial assessment is between an hour and an hour and a half, just to ensure that people have enough time. And we've found that that is just about right for the initial assessment. At the end of that assessment, the next thing that we do is work out whether that person truly is suitable for social prescribing, because sometimes they'll come through and it will all look fine, but you might just find that there are things that would make this person unsuitable. Not often, but it does happen. And we do have a look at that as well. And at that point, we then do the action plan. So the social prescribers will then sit with the person, whether remotely or in person, and do an action plan with them about usually 3 to 4 things that can be addressed in social prescribing. We try not to just look at every single thing that's in the person's life. We look at the priority items to ensure that there's a focus on the things that we can work with and in a time frame that is suitable as well. The way that our timeframes work, instead of giving people a number of appointments, for example, I know that some places say they have 6 appointments. We've tried to steer clear of that, because what we found when we started with that model were people were trying to stay for a bit longer, so they would delay their appointment or they would cancel. So we decided to kind of work within a month. So we say to everyone at the beginning, you've got 2 to 3 months with us, and we'll work through these issues with you. Of course, people do stay on for longer than that time, and sometimes it's shorter. But I think giving a sort of a month time frame helps them to make, you know, to use the time that they've got rather than to anticipate and be fearful about the session's about to end. So they're not concentrating on the end, but they're thinking about where they are. The other thing that we do after the action plan is we begin to sort of managing their expectations around the agencies that we'll work with, what it will look like. And you do all of this at the beginning, just so that the patient knows what's to come as well. Next slide. Oh, I think I've missed one, the frequency and time of the SP. I think, again, with that, we are flexible, and we try to ensure that the patient is seen based on their need. So, you know, as you build the package, you ensure that the person is at the center and that they have the amount of interactions that's needed for them. And, you know, in the beginning, you may speak to someone twice a week, but you'll know that the support is getting put in place as you speak to them less in that time frame of 2 to 3 months. Okay, next slide, please. Yeah, thank you. Our caseloads are between 30 to 35 a month, and that just depends on complexity. We find that that works for us, and however, we're looking at winding that down to a lower number for the mental health social prescribers, simply because everyone that they get is complex and has a diagnosed mental health difficulty. Just because it's working well and it's going fine, but at the same time, we want to know that people are not going to burn out or have more cases than they need and not able to sort of work well with the patients that they do have. The expectation is 243 patients per year, and we're trying to hold that line. And if we had less patients per year, that's also fine, but not much more than that. I think that's a sort of maximum for us if you're going to do a quality service around social prescribing. In terms of support structures, we have a number of those. So we have a WhatsApp group. We've got 2 of them, one without I'm in. And in that one, they put cases in or ask questions, and I'm able to reply. And also they help each other in that group. The second one, it's just the social prescribers themselves, and they are able to do a similar thing, but without needing me. What we've also got in One Westminster is a resources officer. And I really would like to think everywhere else can get one of these too. And it's helpful because you've got that person whose focus is on the resources and ensuring that the quality of the resources that we have are up to scratch, that weekly they can continue to update things. And if the social prescribers don't have the time to do research, you can just ask the resource officer who's able to go and do some of the research and come back to them with extra things. But I think what's great though is that keeping up of that live directory, so it makes what we use really useful. And they've also got me sort of being quite accessible and doing one-to-one casework whenever is necessary. But we've got a strong team, and they've all been in place for, I think, 18 months now. And that makes a huge difference, having the longevity of the same social prescribers and the experience. They have a weekly peer-to-peer group as well. And there they get to bring some of their cases and discuss with each other. We have feedback and review built into the process of supporting. So if, you know, in our team meetings, if they feel like something isn't working or there's something that needs to improve, they can share that in the team meeting, and we try to work through things. And also, I think Leanna's touched on that point around volunteers. For us, we, especially in the beginning of starting social prescribing, we felt that having volunteers were really important in order to really support the program. And it also alleviated some of the things that the social prescribers had to do in terms of physically taking people to like activities. That's the sort of plan we have for them anyhow for the future. And that's something we're actively looking into right now as things have opened back up. In the beginning, however, the volunteers were doing a lot of the chatting roles and ensuring that people were okay. We have an Excel spreadsheet to try and track the patients, and we've tried our best to ensure that each person has their own page and each SP is able to access that for themselves, and they've got things like color coding and a number of other ways of ensuring that the spreadsheet's up to scratch. It took us possibly 2 months, I would say, to collaboratively to sort of get this to work in the way that we wanted it to. And we just kept going back and forth at the beginning to ensure that everything was in there that we wanted. But I can send a copy of this later so you can see how we work and what that looks like, if that would be useful. We've just updated it, hence I don't have a sort of dummy copy, and I wanted to send you to show you the latest version. But however, we're also slowly transitioning to time to spare. That looks like it would be a good platform to do some of our work from, but we'll see as that goes. But at the moment, the Excel spreadsheet looks really good and it works really well, but I think we want to do better at getting our data collection, hence the moving over to time to spare. So crucial to caseload management. I think knowing your boundaries is key. Knowing where SP begins, where it ends is really, really key, and being sure of those and sticking to them. And I know often in the PCNs, you'll get pushed to do things or get asks that are not really related to social prescribing. And this is where understanding your why for your boundary and protecting the service that you work for and your professional boundaries around social prescribing is important. We have an admin day built in once a week. We also use that 1 day a week to have things like trainings as well, but usually it's for admin, and that just gives the social prescribers time to stop and look over the Monday to Thursday bit of their work and see where they can build for the next week. So every Friday is admin day. That's something we thought about from the beginning and ensured that we built that in with the agreement of the PCNs. I'm not sure how happy they are with our admin day still, but we continue to say that it's important because it really is. And we find that the social prescribers are benefiting from it, and the service benefits from having that day where they can stop and really look at everything in their work and plan better. The traffic light system really helps in terms of prioritizing their work. But again, there's flexibility around this, and each person has a different way of working, and to be able to respect that's important. And the sort of flexibility around, the way that people work, but at the same time ensuring that we get the data that we need and the sort of consistency in the service as well. And managing expectations. So managing their own expectations is important because, I think people in the role of social prescription as social prescribers, you're there because you want to help people. That was the reason you applied for this job and are in that role, and realizing at times that you don't have all of the resources in order to do this. So it's not just managing the expectations of others, but also those of yourself as well. And being systematic is important, being able to log things as you go. The last thing I'd say is around the GPs and the PCNs. So we get all of our referrals through tasks and emails, and there are times that they're inappropriate. And when they are, it's having that confidence to say no, and to stick to your no, and remembering why your no is the right thing. And also that confidence to remember that you are the expert in social prescribing. They're not the expert in social prescribing, it's you. And being able to stand by that with confidence, I think really will empower you in your role to do it well. They are medical experts. And I know that, you know, we had recently someone in the PCN said, you know, the service you're running is a gold star service, and you've got, you're seeing 2 to 3 people a day, sometimes 4 at maximum. This doesn't seem like really enough. And having to explain why that's more than enough and how the social prescribers spend their time and what makes this a good service and what makes it a quality service was an interesting conversation, because we were coming from 2 very different schools of thoughts. And I think, again, you know, it's just kind of holding on to that. You are the expert. Next slide, please. Yeah, and I've put these again as my top tips. I've repeated them because I want you to hold these as your top tips. Knowing your boundaries and sticking to them, both with yourself, with the PCNs, with the patients. Building in that admin day. If you're not able to do that for yourself, being able to speak to your managers and explain why that could be important, and the way that your work looks now, and the benefits of this. We didn't call it an admin day at the beginning, we called it sort of training day. And we're, you know, being able to show the different things that could happen in that day. We could have meetings, they can learn new things on that day, but also, you know, the key is being able to prepare for the week coming. The traffic light system, I can't emphasize enough how great that is, because it just means that you're prioritizing your work in a way that you will be able to work well. And being flexible. As much as we want to help everyone, I think being able to be flexible with yourself and being able to be flexible with your caseload, and, you know, to be happy that some days you only have that one person that you can get through, because that one person and their work, it's so time consuming, and just being confident that that is okay. And because most days you don't see one person, but there are days when that happens. And yes, managing expectations and being systematic. And the last slide, please. Okay. So discharge. So for us, on discharge, we do a few things. When we know that the key priorities are met, we send an email or a letter, depends on whether the person's digitally included or not, summarizing the work that we've done together with them. And I think that helps patients to see their journey, because sometimes they might think, oh no, I haven't achieved anything, nothing's happened. But you're able to show that if you can put it in sort of a summary. If anything is outstanding in social prescribing, so there are some things, I'm sure for everyone as well, that may not come through for 6 months, and there's no sort of point in holding on to someone in your caseload because you know this thing will come through in 6 months' time. It's just that they have to wait. With that in mind, you give them the contact number, the phone, the email, everything that they need in that discharge summary, and also reminding them that they can come back to social prescribing if it's needed. If it's necessary, they can go through their GP, just remind them that you're there, but they will just need to, you know, start again in a sense. And leaving that suitable pathway open. Ending the sessions. So I would say one of the key things that come up for us is cases that are complex certainly can go beyond 6 months. And that's just the nature of people with extremely complex lives, and being able to be flexible around that is important. It's not for most people, our average is 2 to 3 months, but there are cases that go on for 6 months, and that's okay. Also, we have people who want to keep social prescribers next to them, tethered to them as much as possible, because they fear that losing the social prescriber may mean that their life becomes chaotic again, or these things could change. And I think it's just, as you work with them, is building in that sense of it will be okay, you'll get there, but also there's a route back to us if that happens. But however, most people are ready to move on by the time we are finished working with them. And we've also got 1 or 2 who are so empowered at the end that they become a little bit embarrassed about needing social prescription in the first place. And for us, that's a good thing. It means that they're so empowered that for them it's like, oh my gosh, there's no way that I needed that service. And that's fantastic. In terms of struggling, so I think outline in the beginning what they might need and what they'll get from the service. That's everything. You know, in that first interaction, that first initial assessment with the patient, is just letting them know this is what it looks like. This is what the journey could look like, and this is the time period that we're working with you, that we could be working with you. And just let them know that nothing is hard and fast, but this is likely what it will be. For myself, often when I'm supporting a social prescriber with a one-to-one caseload, one-to-one case, I think not having that personal connection helps, because I'm able to sort of stand back and look at the input for social prescription and to see what else is needed, or if they've already done everything. And often in our conversations as we speak, you'll find that the social prescriber has done what they need to do, and they will get to that answer themselves. And I'm just guiding the conversation really for them to realize that they have done it already. And I think that's probably the best and sort of support that I give to them. In terms of training, most of our training is done in-house, and trainings that we've built, and usually built based on the need. So you have someone say, oh, I feel as if I'm lacking in this and this is missing, or I'm not sure about this. And as I listen and hear the different things that people need, I'll make a log of it, and then eventually we'll think, okay, maybe what we can then do is have a conversation about this or build something around it. For example, our mental health social prescribing team, we were using ONS4 for our patients throughout the service, and realizing that that didn't work for our mental health patients. Stepping back and being able to build our own tool was an important thing. And we are about to do a review on that in 2 weeks, so I can tell you how that works at a later date. But it's things like that. It's just being able to work collaboratively with the team and respecting that they do the job on the ground, and I may oversee and understand quite a bit of it, but to work together in a way that's helpful for the whole service. I think that's the end of my presentation.
It's amazing. Conchia, you're getting loads of lots of gratitude in the chat, all such fantastic advice, and I feel like you've stepped on a number of things, covered a number of things. I think the importance of stepping back, being able to get some perspective, understanding, taking a look at your caseload if you're feeling overwhelmed and there's too much, the list is too long, and that you feel like you're not getting to people, giving them the support that you think that is the quality service that Conchia was talking about. Having that time to be able to take a step back and think about how you might tackle some of those cases that maybe it is time to move on. You don't have social. Dave was talking earlier about social prescribers not being superheroes. I think it's communicating that to the patients and the clients, but also the context and the system that we're working within. Social prescribing is still fairly new, and I think it's seen as the answer to a lot of things, and being able to have the confidence to push back and be really clear about the boundaries of your role is going to hugely help. And whether that is in terms of the stuff that you're being given, the number of I mean, it's really shocking to see some of you are working with such high caseloads. Link workers should be working with between 2 to 250 cases per year. That's outside of the COVID context where you were making the welfare calls. I think this idea of boosting the client and empowering them, so by the end of it they feel the work that you've done with them makes them feel ready to perhaps when things like this come up again, they've got the assets within themselves to find their own solutions. It might be that they come back, or they might engage with the service further down the line for something else. But it's thinking about how you can empower that client and really reflecting back to them
Okay, so we've got a problem with Liana's connection. Liana, are you here? Okay, let's see whether we can ask Liana.
I got kicked out. I think the last thing I wanted to say was peer support and leaning on each other. And I was going to say to everybody, some of you will have really effective, some of you have really effective peer supports in your local boroughs. If you're in a borough where you're not that well connected with other link workers in your borough, do get in touch with us, because we'd be really up for supporting you guys and setting up a local borough level peer support. We've worked with a couple of boroughs that have now got a WhatsApp group, a Teams channel, a shared list of all the services that they might refer on to, and these are link workers that are working across a few different organisations. So please do drop myself or Justina a line if you're a link worker in a borough that doesn't really have that kind of infrastructure but wants some support in getting it set up. We can definitely help with that. We've got a few minutes left. Is there anybody? Can we open up into the so we'll be sharing the recording and the slides with everybody. It'd be nice to see some faces before we go. Is there any other comments from anybody else on today's session? Tips, top tips you've got, things that you think we haven't mentioned today that you think is really important in terms of, you know, having an understanding of your caseload and making sure that you're not overloaded?
Liana, sorry, I was just thinking about when you set up that group with Camden, and how we all were. You said, "Oh, you can set it up and you can do your own time and everything." We were all saying, "Oh, but we need you there. We need you there," and it's just the same thing as with the patients, isn't it?
Yeah, and actually, Camden is a good example, because I was there at the beginning with you guys getting it set up, and I guess it's getting enough scaffolding in place so that you guys can carry on. And actually, you know, my thoughts on how you can run your peer support is going to become outdated very quickly, because you're going to start having that's going to lead to you having conversations with each other and understanding how you can best support each other. And I think going to your peers with your caseload and saying, if you don't have a social prescribing manager like somebody like Kunshia there, maybe be thinking about how you can build in some time to support each other, going through thinking about which, you know, asking yourself, maybe you have that as a regular thing on the agenda, which of my cases should I be moving on now? Any other questions or thoughts?
What is A, B, or C?
What's that, sorry?
Somebody's put in the chat A, B, or C. What does that mean?
Unfortunately, I can't speak because I'm in a waiting room. It's just about complexities. C being a red, A being a green, B being a amber.
Yeah, I think it's being able. So, are you talking about managing? So, being able to look at your caseload and think about it in terms of what percentage of more complex cases you're dealing with? Yeah, I think that's it's a very smart way of working. In order to push back with your PCN, you're going to need to impress upon them. You might have what looks like a very manageable caseload, but if 50% of those are very complex issues that you're dealing with, then I think it's thinking about them reducing the number that you have on your caseload, and being able to code people and think about so you can start to talk in percentages. You know, I have this number of people on my caseload, but 40% of those are very complex cases. Then you're able to quickly get a GP to understand that actually it's not manageable what you're working with. We're gonna thank you so much to all of the people that have contributed today, and Justina for pulling this all together. The next session we're going to be doing is on supporting patients with cancer. So anybody that has some good case studies or some really great examples they want to share, or have got some questions that they would like answered in that session, please do get in touch with Justina so we can start to pull together some content for that session. And again, we're constantly thinking about what other sessions we could be running. I think hopefully we'll be doing one on how to work with the other personalised care roles within your PCN. We did a session for PCNs a couple of months ago, but I think it would be useful to do one specifically directed at link workers and yourselves. And perhaps we can get some health and wellbeing coaches and care coordinators along to talk about how the three are working together. Justina and I and anybody else that wants to hang around for the next half an hour to chat, please do stick around. Yeah, we'll take a 5-minute break, but we'll be around to answer any questions. And if you want to chat to each other, then please do stick around. Thank you so much, everybody.